Well, let's go ahead and get started. It's just a TIA. What's all the fuss? You know, I hear people say, well, yeah, I've had TIAs, no big deal, and I have to catch my breath because, and I'll show you why. So, well, let's go into what is a stroke. We all know that a stroke is something bad. It happens when blood supply to a region is disrupted in the brain. And there can be oxygen and glucose don't reach the tissues, and so there's tissue death. And with that comes neurological impairment. But so what's a TIA? Well, the old definition used to be it's a brief episode of stroke symptoms due to temporary interruptions of blood flow to the brain. It can last anywhere up to 1 minute or 24 hours, and that was the TIA. The new definition is an episode of stroke symptoms lasting less than 1 hour. With a TIA, there's no damage to the brain. With a stroke, there is damage. So what's the TIA, what's all the fuss about? Well, when we look at this, we have to go do an MRI. If you had a pacemaker in, you may not be able to do this, but if you do come in with TIA symptoms, sometimes we'll go ahead and check the MRI to see if there's actual damage. The head CT scan that people have on occasion, that is pretty much just a black and white image. You can't really see too much with that, except if there's a stroke that's really, really an old stroke, or if there's bleeding in the brain. So why is it so important to have our TIAs evaluated? Because 8% of people will go on to have a stroke within 1 week, and 20% of people will go on to have a stroke within 3 months. So we have to find out why the TIA happened, because we don't want that to happen to people. Through risk factor modification, through total investigation, finding out what happened, we can prevent a stroke from happening. So let's look at some of the factors that are related to people that may go on to have a stroke from a TIA. People that come in with symptoms of TIA where they may have weakness on one side or the other, sometimes they might have a higher incidence of going on to have a stroke. People that may have speech impairment, they may go on to have a stroke. People that have had a series of TIAs, they may go on to have a stroke. People that have heart failure, that can lead to stroke, carotid disease, or who drink excessive alcohol. Those are all symptoms that, through research, we've determined that these people are more prone to go on and have a stroke. But the best thing to do is to come into the hospital, be admitted, and see if we can figure out why those symptoms occurred. And we do that through things like imaging your brain to see if there's anything up there that may lead to stroke, doing a carotid ultrasound, looking to see if there's carotid stenosis. Has everybody understand the carotid ultrasounds? Basically what that is that it's a simple test where they put an ultrasound machine, it's just a wand, and they look at your carotid arteries like this. And it's non-invasive, and they can tell if there's any blockages. I remember years ago having a young man, I say young, he was in his 40s, he's younger than me, and he came in, he had been having symptoms, he'd been experiencing stroke-like symptoms, and here he was in his 40s, although he was somewhat at high risk. He was a smoker, and he had elevated blood pressure for a while, and unfortunately, he did not realize, or nobody realized, that he had had carotid disease, and he actually occluded his entire carotid. At that point, he had a terrible stroke. And these are the types of things, we know the incidence of stroke is higher as we get older, but what we're finding is that the incidence of stroke is also getting higher with our younger people too. So just something to keep in mind. A blocked carotid can cause a terrible stroke. We also want to look and see if people have atrial fibrillation. Atrial fibrillation becomes more and more common as we get older. And with atrial fibrillation, there's a higher incidence of stroke. How that happens is that, you have your heart muscle, your heart's right here or whatever. The atrium are on the top of the heart. The ventricles are on the bottom of the heart. Now the heart, beats and beats and beats. And the ventricles are the workhorses of the heart. They just push all that blood throughout the body. They're great. The atrium basically are the chambers on the top that actually initiate the response of the impulse for the heart to beat. When the atrium are fibrillating like this, because, and you know, the ventricles, they don't really care what the atrium are doing. They're still beating and beating and beating. The atrium may fibrillate on the top, and that causes blood to not flow in the atrium. When blood doesn't flow, it can clot up. And so with atrial fibrillation, people have a higher incidence of having blood clots that can actually be pushed throughout the body. So that can be a very, put people at higher risk for stroke. We also will do a TEE, which is a test that we can actually look at the heart, the chambers of the heart, and if somebody may have an actual clot that's resting in their heart, they would be at a higher incidence of stroke. They also may have a small hole in their heart. They can be at higher incidence of stroke. The other thing, of course, we look at is cholesterol. We want your cholesterol to be low, and other different types of tests like B12. Certain things can put people at higher incidence for blood clots. So if you would come into the hospital after a TIA, we would do all these tests. Not all of them, but some of them, just depending on your presentation. And that way we can eliminate your risk for going on to have a stroke. Well, let's look at some of the facts. Stroke is the nation's 4th leading cause of death. This is actually good news because about 2 years ago we were the 3rd leading cause. So we are getting better at treating stroke earlier, and you know, people are not dying of it. We also, though, find that 780,000 Americans per year have a new or recurrent stroke. So that's rather sobering. Stroke is the leading cause of disability, which is terrible, because we know living with disability is very hard. Over 4 million Americans live with the effects of a stroke, and stroke disability is very expensive. It costs $52 billion annually. So let's also look at the types of stroke. First, we've been pretty much talking about ischemic stroke. That's 80 to 85% of all strokes. And there's many different causes of ischemic stroke. There can be small vessel, cardioembolic, or large vessel, or other causes. Now, let's just talk a little bit about those different types of ischemic stroke while we're on that topic. If you think about your blood vessels as a tree, all right, and if you think about your carotid arteries as being the base of the tree, and basically they go up and they branch off to other arteries at the very top of the brain, when you have small vessel stroke, we're talking about the branches at the top of the brain that are closed off. That would be small vessel stroke. Causes for small vessel stroke happen as we get older. They may be due to things like high blood pressure. They may be due to things like diabetes, things that actually might damage those little tiny vessels in the brain. High cholesterol is another cause of small vessel stroke. Large vessel stroke, that was what we were talking about with the carotid arteries. That would be termed large vessel stroke. It can happen here, or it can happen on 1 or 2 of the other larger vessels in the brain. And so that would be the cause of large vessel stroke. And then cardioembolic, we had talked about atrial fibrillation. That's stroke that comes from the heart. That's why we call it cardioembolic type stroke. Hemorrhagic stroke is about 15 to 20% of all people. There can be 2 different kinds. There can be subarachnoid, which is one of the little linings in the brain. An aneurysm can burst in there, and it can have blood infuse all over the brain. Subarachnoid is extremely serious. Aneurysms, as you probably know and have heard, are extremely serious. If people have a burst aneurysm, it's oftentimes fatal. So, and then intracerebral hemorrhage, that is another hemorrhage that's more on the inside of the brain. And that can be caused due to high blood pressure, things like that. So you can see the pictures here. Hemorrhagic stroke, the blood leaks into the brain tissue there. And then the ischemic stroke, the blood's just not getting to that blood tissue or the brain tissue there. About 1/3 of people who have strokes, who are stroke survivors, may have another stroke within 5 years. That's kind of sobering. So what we find is that secondary stroke prevention is extremely important. At Mercy, we have taken this to be a real cause célèbre. We started in 2008 a stroke clinic, so we see all patients post-stroke and post-TIA because we feel that it's really important to manage those stroke symptoms and manage their risk factors so that they don't go on to have another stroke. So that's one of the things that we've done at Mercy. So let's look at risk factors. Many of you probably are all well aware of these risk factors. High blood pressure, a big risk factor. Now why would that be? Well, let's just talk about that a little bit. If you think about a blood vessel, if you think about the pressure going out against the blood vessel, continuously going out, your blood vessel actually fights back. And when you guys think about the term hardening of the arteries, do you guys remember that term being used years ago? They don't use it very often anymore, but it's really apropos because what it's showing is that the arteries are getting harder and harder on the outside because they're constantly pushing back due to the high blood pressure. So they get harder, and when they get harder, they're less compliant, and they're more easily damaged. Easily damaged blood vessels create problems. They create flow problems. You may have a platelet that's going along in the bloodstream, and it says, wow, there's a problem here, there's damage there, I'm going to go fix that damage. And so the platelet may lodge up against that blood vessel where the damage is, and guess what happens when platelets get together? They cause a clot. That's why a lot of us take stuff like Plavix or aspirin or Agranox, because that's an antiplatelet. It keeps platelets from clotting. So that's how high blood pressure can be a problem. Also, damaged blood vessels can collect plaque from high cholesterol. So that's why we constantly tell people, keep your blood pressure low so that you're not damaging your blood vessels. It's very important. We recommend keeping blood pressure 120 over 80. Some people ride with it at 130, and they are kind of okay with that, but I still would really like to see that under 120. If you have too low a blood pressure, that's good. Clearly you don't want to faint, if you're taking blood pressure medication, but if you're just naturally somebody with low blood pressure and you can handle it, that's great. You'll keep better blood vessels. People with coronary artery disease and high cholesterol, that's another risk factor. We look at total cholesterol being less than 200. And what we want is HDL, the good cholesterol, to be greater than 40 if you're male, greater than 50 if you're female. We want the LDL cholesterol, the terrible cholesterol, bad cholesterol, to be less than 100. And if you have diabetes, we want that to be less than 70. These are all guidelines. The cool thing about the HDL cholesterol, we're going to talk about that more later, is that it actually eats the LDL cholesterol, or it helps to decompose it or get rid of it in your system. So that's why we really want the HDL to be high. And then diabetes, clearly that can be a risk factor for it. Just diabetes, unfortunately, can destroy your blood vessels. What we find is that if people keep that diabetes under control with oral, diabetes medications or insulin, that you're much less risk of having damage to your blood vessels. And then, of course, if you have TIA, please seek medical attention right away to prevent a full stroke from happening. Uncontrollable risk factors, things we really can't control our age. We're all getting older, and so that's kind of a drag. But we find that 2/3 of all stroke happen with people over 65, and the risk doubles past age 55. Now, I want to say something about this for all the kids who've had strokes. We have a group of women who are in their 20s and 30s who are part of our stroke support group. They're just a great group of kids, I call them. And we need to be aware that young people can have strokes too. And I say this to you guys, and I say this to school kids, and I say this to medical professionals, because sometimes when young people have strokes, we don't recognize it right away, because we're like, well, you're too young to have a stroke, how can that be happening? So the point is that anybody can be at risk for stroke. If a kid has a stroke, say someone in their 20s, it can be it's clearly due to different reasons than when you have a stroke when you're older, but it can still happen. We find that women that smoke and take birth control pills, sometimes that can cause their blood to clot. And when their blood clots, it can send strokes to their brain. We can find that women that are even on just birth control pills and don't smoke, sometimes that can happen. Sometimes we have patients who have holes in their heart. They can be at higher incidence, higher risk for stroke. So these are all just things that happen. Just keep that in mind. If you see a young person that has stroke-like symptoms, that is also 911 to the hospital right away, because we want to take care of that. We find that males have a slightly greater risk than females, but what we also find is that, guess what, girls, that's changing. Unfortunately, as we have a higher, more type A personality, we're at much greater cardiovascular risk. So I see that averaging out. African Americans are at the highest risk, with Hispanic Americans are next at the highest risk. However, still white Americans are also at a very high risk too, so just keep that in mind. And people that have had a family history of stroke, they are at higher risk. And of course, as we talked about, diabetes. Now what can we do? What types of changes can we do so that we're not at risk? Smoking is really bad, and I tell everybody if they smoke, they need to quit right away. And I know it's really hard to do, but they are doubling their risk of stroke, so they really need to quit. If you drink more than 2 drinks per day, you need to, alcohol, you shouldn't drink more than 2 drinks per day. For men, that's 2. For women, it's 1 drink per day. If you don't drink, don't start, not time. And then weight, just need to keep your weight down. It's a strain on your circulatory system, so it's just really important. Also, high blood pressure and diabetes are related to having higher weight, so it's just really important to keep that down as best you can. And then exercise. Well, we're going to continue to talk about that, but it's really necessary because it helps with circulation and it helps with weight problems, just overall health. So what does this look like? Well, if you would do a walking program, say you would walk an hour a day, you can decrease your stroke risk by 46%. That's pretty good, so we really think that would be great. If you can walk 30 minutes a day, you can decrease your stroke risk by 24%. How does this work? Well, by exercising, we increase the amount of glucose that is used throughout our body, so that we don't, become pre-diabetic. In other words, if you can increase that glucose, it actually goes through your cellular structures a lot easier. You can even, it transfers over into your cells a lot better, and even they say that your body requires less insulin if you can exercise, so that's really good. Clearly, exercise decreases your body weight and fat stores. It also can decrease your blood pressure. Now, sometimes that seems a little counterintuitive because you're like, well, wait a minute, I just walked up the steps and now my blood pressure's elevated. But what we find is that for people that are with high blood pressure, that if you are on a regular walking program, you will actually decrease your blood pressure overall. So it's really recommended. So exercise decreases your total cholesterol. It increases your HDL cholesterol. If I see patients in stroke clinic and I see that their HDL cholesterol is low, like in the 30s or 20s and 30s, which unfortunately we see that pretty often, we know that through regular exercise program that can naturally increase. So that's why we really recommend that. It also promotes healthy blood vessels by stabilizing plaque so it doesn't break off and cause a clot in the brain, heart, or lungs. So let's go through stroke symptoms. Just keep in mind that stroke symptoms are all about location, just like real estate. Is anybody in here a realtor? Okay. You know that location is really important. And as in your brain, you find that if you have a stroke on the left side, it's going to look different than if you have a stroke on your right side. In the back of the brain, it look a little bit different than if you have it in the front of the brain. So it's all about location. So one of the symptoms of stroke is sudden weakness on one side of the body. It can be numbness or weakness in the face, arm, or leg. And so what we found is that if you have a stroke in the right hemisphere of your brain, you're going to have weakness on the left side of your body, and vice versa. Left side of your brain stroke, you'll have weakness on the right side of the body. Now why is that? It's because your brain's divided into 2 hemispheres, and those hemispheres actually cross. So all your neurons in this part of your brain actually cross over and go down to the left side and vice versa. So it's kind of fascinating. If people come in with symptoms, before you even see the MRI, you can actually know, or with a good probability, where that stroke has occurred. So anyway, if people have sudden trouble walking, dizziness, or loss of balance coordination, that's another symptom of stroke. Now that symptom of stroke is probably because people have a stroke in the back of their brain, their cerebellum in the back of their brain, and that is where you'd have symptoms like that. This is kind of an unusual stroke symptom. More often we see symptoms that affect this part of our brain. So sometimes this one can be missed. You know, people can say, well, I'm just really dizzy. You know, and they may not think too much of it, or they may have like loss of balance, and they're like, well, no, let me just sit down. I'll feel better if I sit down. And they may actually be having a stroke. So sometimes it's hard for them to know that this is a stroke. But just keep that in mind, that this can be a stroke symptom. Sudden trouble seeing. Again, real estate. This is the occipital part of your brain. It's in the back part of your brain as well, above your cerebellum. And if you have a stroke to that particular part of your brain, you may have trouble seeing. It can be a vision field cut. You know, you may not be able to see one way or the other. I had a lady come into the hospital who, she was driving on the road, and she noticed that she couldn't see the center line. And so she fortunately was able to get to the hospital, and we were able to, you know, note that she could treat her for stroke. But you know, that is something, if you're driving or whatever and you can't see to one side or the other, very easily could be a stroke. Sudden confusion, trouble speaking or understanding. This particular stroke symptom occurs because you have a stroke on the left side of your brain. Your language center is on the left side of your brain, and the ability to understand language as well as the ability to speak language is located over there. So this is where we would see this symptom. And then sudden severe headache with no known cause. If you consistently get migraines, and if you get another headache, it's probably not a stroke. But if you have the worst headache of your life, it could easily be a stroke. And this is oftentimes a hemorrhagic stroke. So just keep that in mind. These are all 911 emergencies, by the way. So what do you do? Well, if these happen, you do not ignore the warning signs, even if they go away. Because guess what? That could have been the TIA that we were talking about. If they come in, you need to note the time of onset. For example, it's, what time is it right now? It's a little after 12? 12:30. Okay. So if a stroke happened right now, we would call 911, and we would say it started at 12:30. You need to, and the reason that we do that, and I can't remember if my, is that time of onset is extremely important with stroke, because we can treat people who arrive fast enough to the emergency department. So you call 911, and you have to realize that every second counts. Don't go lay back down on the sofa and think you're going to feel better, because 1.9 million brain cells can die per minute, on average, with stroke if you're not treated. So what happens when you come into the hospital is that we rush you to the CT right away, because we want to know what's going on. We want to know if it's a bleeding stroke or if it's not a bleeding stroke, and that is pretty important to know. We'll do blood work and just be sure that your clotting times are okay. We'll look at we'll monitor your heart, and we'll listen to your health history. And what we will do is see if you're a candidate for TPA. TPA is tissue plasminogen activator. It's actually a naturally occurring substance in your body, but it's something that we can give in a bolus shot form and then drip it over an hour period of time that actually assists your body to break down clots. And so what we do is we'll assess to be certain that you're a candidate for that, and if you arrive within 3 hours, we would be able to treat you. Some people we can go up to 4.5 hours for treatment. So that's why, you know, it's important to come in right away so we can assess. And then what we do is we also note if there's bleeding in the brain. If you do have that kind of stroke, the hemorrhagic stroke, then we would determine if it's an aneurysm or intracerebral hemorrhage. Some of these things require surgical intervention. You guys have probably heard about clipping aneurysms and things like that. That would be something, if we noted that you had an aneurysm, you would probably be sent down to the university, because the university is the only place in Iowa, as well as I think Mercy Des Moines, but there's very few places that will actually work with aneurysms. And we will keep hemorrhagic strokes, however, intracerebral hemorrhagic strokes, at Mercy, because we do have neurosurgical coverage. These are the measures that we control with the primary stroke center, so you can kind of see how that works. We will look at TPA. We also take good care to be sure that if you need an anticoagulation that you're sent home on that. We check lipids, we educate, and we evaluate for rehab. I'm happy to answer questions and, see how that goes.
Two real quick questions. My grandfather and father both, I think, died of stroke. How much greater percentage am I because both of them died from the results of a stroke?
I wish I had the exact percentage for you, but I know that you are at greater risk. So, but the thing is, you have to determine why that stroke happened with them. I mean, they could have had a hemorrhagic stroke, or they could have had untreated things. So, that's why it's just really important to, figure that out. I mean, it's kind of hard because my grandmother, I know, died of a stroke. And to this day, I'm not certain if it was hemorrhagic stroke or ischemic stroke, but I have no way to get into those medical records, so that was a long time ago. So it's hard to know.
Thank you. My other quick question is, with my arms, when they take blood pressure, at least this very last time, there's such a big difference between the two.
So that, I was just reading an article about that. I just saw an article in reference to that in terms of, the two differences in blood pressures. I wish I had finished reading it, but I did not. But the point is that I know that may put you at higher risk for vascular disease if you have those differences. So, but you do need to take in both arms. And typically I would go with a lower reading in terms of your risk, yeah.
Okay, because there was like 24 degrees or points difference between the right and the left.
Right.
Being the right had the lower.
Right, well, we certainly wouldn't want to treat you for high blood pressure based on one arm versus the other. We may over-treat you, and then you may, have difficulty getting blood to the brain. So that's another problem. So,
One quick thing, I stopped at Mercy Hospital one time because I thought I was having a stroke. And they gave me that pill that blew the top of my head off, and I didn't like that. It's just like somebody was pounding the top of my head with a hammer.
Okay, you're talking about, were you actually admitted?
Yeah.
Okay. There is a medication that's an antiplatelet medication, it's Agranox. And on occasion, that medication can cause severe headaches. So that's kind of one of the side effects of that particular medication.
I thought it was something different, but maybe I'm wrong.
That's the typical, that's the typical course, yeah.
Yes. I mean, that was 20 times worse than what I felt when I came in.
Yeah. Over here?
Two questions, actually. You said there's typically no residual damage from a TIA. Is it possible for there to be? My mother-in-law's had 5 TIAs, 3 of which have been in the last 2.5 years. And she says things have changed since she's had them.
Then your mother-in-law has had a stroke.
Would you please repeat that?
Okay. Her question was, her mother-in-law has had 5 TIAs within the last 3 years, and she feels like she's not 100% where she was. And my comment to her was that her mother-in-law has had a stroke. Because if we would do an MRI, you can bet that there's going to be some damage up there that perhaps has not been diagnosed yet.
They've done MRIs and CTs on her, and one doctor in Vegas said there was acorns left, like little acorn marks.
Okay.
And here they said there was no marks.
Okay.
So
she said that there has been an MRI done, but there didn't appear to be any damage. But it's possible she may have something called small vessel disease, and that's where, as we age, we get small vessel disease. Remember we talked about the little tiny vessels? Sometimes they do just close down, and sometimes people can be symptomatic due to that. But, I always say that, sometimes people, if you have cumulative damage in your brain, there could be silent strokes where you don't even know that you've had one. And then we'll do an MRI and note that there's several small strokes up there that people are not even aware of. So that can happen too. Yes?
With the symptoms that you told us and how there's different areas of the brain that would be attributed to, if a person had, say, a carotid artery on one side or a blockage on one side, would there be an area of the brain more prone to having a clot come from that area? Would
Okay.
it be the back of the brain?
Okay, that's a very good question. Thank you for asking. Her question was, if you have a carotid artery blocked, what would the symptoms look like? So what we can do is we can divide the arterial flow system into parts of the brain too. Your carotid arteries feed this part of your brain on both sides. So if you had a left carotid artery blocked, for example, then you would see damage on this part of your brain, which would control your right arm, leg, and face, as well as your language. All right. If you had your right carotid artery blocked, it would do this part of your brain, which controls your left arm, leg, and face, as well as integration of information, which is kind of interesting. So oftentimes people with right hemisphere blockages, due to their right carotid artery being blocked, they actually may not appear to be as symptomatic as the left side of their brain being blocked because they can still talk. But the problem is they oftentimes don't realize they've had a stroke because they're not processing information well. So unfortunately, sometimes these patients will sit at home for a long time with the stroke symptoms, thinking, this is really weird, I kind of feel weird, but I don't know, my left arm can't move, but oh well. And they never call 911 because they don't realize that they've had a stroke. So that's kind of the sobering part. If you have blockages in the back of your brain, like we talked about, the cerebellum, or your occipital area of your brain, that's oftentimes your vertebral arteries. Now, you think about how your vertebrae work. They actually will, there's holes in the vertebrae, they go up in the back of your neck. Within those holes is actually where the vertebral arteries rest. So that's kind of an important thing to know because it protects your vertebral arteries in one hand, but also if you get in an accident and you have whiplash, you can actually dissect or damage one of those vertebral arteries. And so that can be a situation where a young person may have a stroke because of damage to a vertebral artery or something like that. But in any case, those vertebral arteries back there, those are what control your cerebellum and your occipital part of your brain, kind of some of the back parts of your brain. So that's how that works. Yes?
I have a general question about those sensitive to or allergic to aspirin, and I saw aspirin mentioned once. For instance, this TPA, would that be, is there any difference in what you've shared for those of us who are sensitive to aspirin?
Well, your question was about being sensitive to aspirin, if that might be an issue with receiving TPA. No, they're not. They're not related. TPA is it's an actual. It actually gets into the clotting mechanism and helps break up clots. Aspirin's an antiplatelet. So that's kind of how we look at that. Those people that are sensitive to aspirin and may have an allergy to aspirin, what we recommend if they need to have an antiplatelet would be going like to Plavix or something like that. So. Yes.
Is a TIA just diagnosed on symptoms, or is there specific testing they do for a TIA?
That's a really good question. Her question was, is a TIA diagnosed on symptoms, or are there special tests? And it's pretty much symptoms and not having damage on MRI. That's kind of how you would diagnose it. So unfortunately, we have no other way to do that, because in order to be a TIA, there has to be no damage. And the TIA symptoms are basically stroke symptoms that only last for less than an hour. That would be how we would diagnose that.
So the TIA, a small clot that just goes through then?
Yes, interestingly, our body is clotting and declotting all the time. That's how the whole system works. It's a clotting mechanism. If you guys remember that from biology a long time ago, which many of us have probably tried to forget. But, it's that whole clotting mechanism, and it reverses and goes all different directions. And so, basically, your body took care of the clot, which is, it's great when it can happen.
I have visual impairment. I don't want to say periodically, I guess, I'll get vision, and they told me that's a symptom of TIA.
Yes, it is.
I'll get blurry vision, but it'll last 5 minutes, it goes away.
Okay. So, His comment was that he has blurry vision that may last for 5 minutes and can go away. That can be a symptom of TIA, and you know, if they checked everything else out, if they checked out your carotids, if they did an MRI to see if there's any damage up there, if they have checked your cholesterol, if everything else is treated, you're taking your aspirin, antiplatelet, medicine, then that's all we can do. Pretty much. But I mean, that's why you just have to monitor it, just to be sure that nothing else can happen. Because we don't want to give you TPA unless you have to have it. There is a certain risk with that medication.
It's happened to me when I'm sitting watching TV.
Mhm.
It's happened to me on a golf course.
So there's nothing related to activity. So just continue to follow up with your physician and be sure that your risk factors are taken care of. And be sure that you keep, I mean, have you had an MRI then, or, okay?
I don't know how long ago this was. Maybe you know this colleague of yours from the University of Hospital in Wisconsin, Dr. Silverstein. I don't know if you know him.
No, I do not.
Yeah, I had what he diagnosed as third nerve palsy.
Okay, that's another one.
My left eye went over here and stayed over here.
Okay. Yeah.
I was up there. 6 months later, it's back to normal. No treatment. I mean, no surgery or anything.
Right.
It was palsy.
Yeah, that's an easy one. It's a little bit, because typically you would get better with that. So he's talking about a third nerve palsy. That we have these cranial nerves throughout our body or throughout our brain, and they just do different, control different muscles and things like that, impulses. So. There's a question here. Oh.
I just wondered, since he has these occasionally, would it be a good idea to document them so the next time he went to the doctor he could talk about it or bring it up? Or?
I think so. Her question is, if you've had symptoms of TIA that happen on occasion, is it good to document? I would think so, yes. But the other thing is, always be aware that if they don't go away, you need to go into the hospital right away. And that's huge. So, yeah.
My mother has had a couple of the TIAs, and each time we went in, and I did the symptom thing at home, studied enough, and I could tell it was just a lapse in memory. Both times we got to the hospital, they did the ultrasound, the TEE, the monitor, the MRI, and it was nothing. And except for the TIA, which is big, but her memory came back, everything was fine.
Good.
But I'm sure a lot of people that are younger than me and have parents in this situation, she's saying if it happens again, same symptoms, don't take me to the hospital. It's just the memory loss. You've done all the testing. They don't want to go through the TEE scan, they're monitoring again, the ultrasound again.
So what do you do?
Yeah.
That's a tough one. Did everybody hear that question? Okay. I mean, what do you do if it happens over and over and over again? And a couple things. Once you've had carotid ultrasounds, you don't need to have them again for a couple of years, okay? Because carotids don't change that much. I mean, your carotid's not going to become blocked right away. So that you don't have. And once you've had a TEE, you don't have to have that again. So when you go in for workup, the workup will be less each time. But the issue with that is that what if it doesn't go away? And then you've missed the opportunity to treat. So that's
Is
the
that
problem.
something that I could monitor from home though, having been through this and doing all the education and documentation that I can? Is that something I can monitor from home and keep testing her and
You mean keep asking her if she's having symptoms?
and do the, toe up to the knee and slide down and the peripheral vision and doing all of it, and still to me just a short memory lapse? Is it absolutely necessary each time to go in for a TIA?
If you're seeing the very same thing over and over again, and you're not seeing any other symptoms, it's probably not necessary to go in. Now, I say that very hesitantly because I don't want to miss something.
Right, but it said less than an hour, and we would
Right.
still be there well within a 4 hour,
Right.
if it gets to 45 minutes, and I say, you know what, this is different.
Yeah.
So it could possibly be, if they're adamant about not going, just monitoring it for the first 45 minutes.
And seeing if something changes.
Okay.
Yeah. Yeah, because if you have taken care of every single risk factor that you can possibly think of, and if you've had the full workup, we're not going to change anything that you're doing.
Right, because I can't imagine for blurred vision if it happens often, him running to the hospital every time to say, that, you know, you've got to come to a point where you can monitor it, I would think.
Yeah. There is another test, you know, we do the MRI, you know, that just looks in there, it's a really good test. We also do something called an MRA, which is basically it's an angiogram using the MRI machine, and that way we can actually look at every single blood vessel in your brain, and that's a pretty cool one too. So that's something else to think about doing too. And if we can, you know, sometimes people have what we call extracranial disease, which is the carotid arteries, or they have intracranial disease, which is that tree up there, you know, and we can see if there's any blockages. Some blockages we can do things with, like send you to the university and do some stenting. Other blockages we just can't, you know, it's just what we have to live with. So, any other questions? One more here?
Maybe this has been answered here, but very quickly. Has it been proven that the 81 milligram aspirin is beneficial?
Yes.
Okay.
81 milligram aspirin is kind of that's what we always use. If you're religious about taking aspirin, you do it every single day, then you can go with 81 milligrams. The only time I've seen neurology bump the dose to regular size aspirin, 325, is when people don't remember to take it every day. And then sometimes they'll go up to 325, but 81 milligrams is perfect. Yeah.
But there was a study that came out, it was on ABC National News, that there was a new study. Are you familiar with that?
There's a bunch of new ones all the time.
That they were saying that maybe that's not as...
That's good.
Yeah, as
Well,
what they originally thought.
What they're finding, and I'm not familiar with that study, but there are two other medications, Agrinox that gave you the headache, and then Plavix is another medication. Those are two additional antiplatelets that have been proven to be more effective than aspirin. I feel like a drug person, drug company telling you that, but they are a little bit more effective than aspirin. If you come in with stroke-like symptoms and you're currently on aspirin, oftentimes they will bump you up to a different medication because they call you an aspirin failure. So that sometimes they'll go ahead and bump you to another medication.
Thank you.
You're welcome. Okay?
What are the insurance complications if you go in and think you have a TIA and they say, hey?
You don't? Well, oftentimes they will admit you under observation to see if you do have a TIA or symptoms of that. So I don't know very much about that particular aspect of it, but I think your insurance companies need to pay, because honestly, if you go on to have a stroke, it's going to be a heck of a lot more expensive than if we find the cause of TIA. Okay, let's do two more questions. There's one over there and then one up here. Yes?
Yeah, about 10 years ago I had what I call a small stroke. And this past year I talked to a doctor about it, a specialist about it, and he was really upset with me for calling it a small stroke. He said you had a TIA. And it just really emphasized you had a TIA.
Well, and that's true. His comment was that, is a TIA a small stroke? And no, it's not. TIA, there's no damage. A stroke, there's damage. And how they determine that, once again, they have to do an MRI of your brain to see if there was any stroke damage there. You know, sometimes people may have had a stroke, but they have no symptoms. And so you may have had no residual symptoms, and there may be no damage, and then it would be a TIA, which is transient, not permanent. One up here.
Yeah, okay, let's say you're on the baby aspirin, and all of a sudden you get these symptoms, weakness on the one side, in the mouth. So should you take a full aspirin right there, then call 911?
I'm so glad you asked that question. The question was, if you are taking a baby aspirin and you have stroke symptoms, should you take a full aspirin and call 911? Stroke is not heart attack. Now, they say sometimes if you have chest pain, that take a baby or take an aspirin because that'll help. But with stroke, remember, 15% of all people might be hemorrhage. So we recommend not doing an aspirin and calling 911, just calling 911, going in, getting the head CT, which we do absolutely right off the bat. And then if there's hemorrhage, then we would not clearly do aspirin or TPA. But if they're, you know, if ischemic stroke, then you would get, you know, TPA potentially in the emergency department. But that's a very good question. Thank you.
Diane, can I ask one more question?
Okay, just one more, and then I think we probably, and then I'm happy to stay and answer questions too.
If it was a hemorrhage stroke, would the person be able to make a decision, or should we discuss with our parents if the aneurysm and major brain surgery is needed, if that's something they want? Would they be able to make the decision at the time, or should we know that ahead of time?
I think always knowing what your parents want ahead of time is important,
Okay.
which means I gotta go make a phone call. But I mean, seriously, and for all of us, you know, I mean, we all need to have advanced directives of some type so that your loved ones know. I mean, I need to tell my kids what I want to do. So, you know, that's a really good question
Thank
too.
you.
Yeah. And I'm happy to stay, so.
Thank you, Diane. I knew this was going to be a very good seminar, so